We continue our series of FOGSI ICOG Harmony on the endocrinology in women. This is our episode 3 in association with Endocrinology Committee FOGSI. I would want to extend my welcome and this thing to Dr. Sunita Tandulwarkar. Madam is president of FOGSI ICOG. I'm grateful to Dr. Parag Benibale, who's chairperson for ICOG. Dr. Sheila Mane, Professor Ashok Kumar, and Dr. Suvarna Khadilkar. I would read upon a CV of Dr. Sunita Tandulwarkar, Madam. Parag, sir?
Madhu, that's okay. Don't read
Yes, sir.
CVs.
Yes,
Let's
sir.
begin.
So we have our third chapter to be taken by the speakers, Dr. Chaitanya Ganpule and Dr. Manjari Valsangarkar. Both of them are from Pune itself. And the first talk will be on GnRH and its analogs by Dr. Ganpule. He being occupied for a while. We will continue with our second talk. I request, sir, मैं ही introduce करूँ chairpersons को?
No. I will let me address, then
Yes,
let Dr.
sure.
Sarita address,
Sure, sir.
and then
Dr.
you
Manjari.
introduce the speakers, and then Dr. Vaishali Korde will also say a few words.
Sure, sir.
She's a co-convener of the program.
Sure, sir.
All right. So good afternoon. I bring greetings from ICOG, and it's my pleasure to welcome you all for the third episode of Harmony, wherein we want to focus on very basics of gynecological endocrinology, especially for postgraduates. So let me appreciate the work put in by Dr. Chaitanya Ganpule, the convener of this program and chairperson of Endocrinology Committee of FOGSI, and Professor Vaishali Korde Nayak, who's a co-convener and one of the popular teachers from Pune. Thank you, Vaishali and Chaitanya, for carrying this forward. And of course, all the three coordinators, Doctors Madhu, Manasi, and Mansi, who are doing a good job. And let me also welcome and thank Dr. Reena Srivastav, very senior teacher from Gorakhpur, and Dr. Tripti Nagaria, who's a professor from Raipur. Currently, I think she's the dean of the medical college. And today we are going to learn about GnRH analogs and FSH and LH, which are the very basic hormones of ovulation. And I welcome our speaker, Dr. Manjari Valsankar, who's a renowned fertility expert. Welcome, Manjari, for the first time on ICOG platform. And happy learning to everyone. I'm sure it's going to be a good learning experience for all of us. Thank you very much.
Thank you so much, sir. May I request Dr. Vaishali Korde Nayak, Madam, to please speak for few words. I think, sir, Madam's network is...
Good evening, and I would like to thank Parag sir and ICOG team, Sarita Balera Madam, for giving us this opportunity, and my co-convener, Dr. Chaitanya Ganpule, Chairperson, Endocrine Committee. And sir, thank you so much. We have designed this program for all the young consultants as well as students, because endocrinology becomes very difficult to understand. And we have chosen speakers like Manjari and Chaitanya who will make this difficult topic very simple. So looking forward to a nice session. Thank you, Madhu. Please go ahead.
Thank you so much, ma'am. Thank you for your blessings.
Madhu, invite Dr. Sarita if she's there. She was there
yes.
sometime ago.
Okay, sir. Can I please request Dr. Sarita, Madam, to say a few words? Sarita Bhalero, ma'am, can you hear us, please? So, Madam is there, but I think...
Doesn't matter. You can introduce both the chairperson and
sure,
invite
sir.
the first speaker.
1 second.
Yeah.
Sir, I continue this. I would like to introduce our first chairperson, Dr. Reena Srivastav, Madam. She is ex-professor and HOD of BRD Medical College, Gorakhpur. Madam has been past president of UP chapter of OBGY. She has been a past president of Gorakhpur Menopause Society also. Madam is fellow ICOG, chairperson for Research Committee, Indian Menopause Society, and a coordinator for IMA of the North Zone and FOGSI HPV vaccination training. Madam has taken many papers and publications in national and international journals. She has organized numerous CMEs, workshops in Gorakhpur OBGY Society. She's organized SAFOG 2019. She's organized UPCOG 2003, 2016, etc. Madam is also felicitated by Dainik Jagran for her outstanding work, and she's felicitated by Amar Ujala as well. Madam is also felicitated by Global Health and Department of Family Welfare in year 2016. Madam, I welcome you on this platform. We have our next chairperson as Dr. Tripti Nagaria, Madam. Ma'am is Director, Professor and Dean of CCM Government Medical College. She's president of Raipur of the chapter ISOPAB. She's been past secretary of AOCGG. She's past secretary of ISA CG chapter, past secretary of IMS Raipur branch. She's also handled Raipur Society of OBGY as being the past president and published more than 40 papers and 13 chapters in several books. Madam is also corresponding national editor of JOGI Journal, and she's invited as a faculty in 150 conferences and above. She's organized many international conferences like SAFOM, National ISAR, IMS, state conferences, workshops, and CME. She's been recipient of Global Signature Award, and her area of interest has been high-risk pregnancy and fertility. You're welcome, ma'am.
Dr. Madhu, you are muted.
I introduce my first speaker, Dr. Manjari, a senior and a good friend, a guide as well, who's finished her MS OBGY from MUHS. She's given a very short and a simplified CV to us that she's inclined and dedicated in IVF and ICSI exclusively, and she's director and consultant at Bhide Hospital. Dr. Manjari, I welcome you on this platform to talk on to LH and FSH, the overview with clinical application.
Thank you,
I
Madhu.
would want Drs. Reena and Tripti ma'am to give their comments after the session is over.
Okay, thank you.
Thank you.
Welcome, Dr.
At the outset,
Manjari.
oh yeah, hello sir. At the outset, I would like to thank Dr. Parag Biniwale sir and Dr. Chaitanya Ganpule sir for inviting me here, and my warm regards to the senior chairpersons today. I think let us start, as I think we should be on time. Madhu, I'm sharing my PPT. Please let me know if you are able to see my PPT.
Okay.
Just a minute. Madhu, Dr. Madhu.
Working very well.
Sure.
We can see your first slide.
Thank you so much. So let's start. I'm Dr. Manjari, and I'm going to talk about LH and FSH overview with a clinical application. So when we talk about FSH LH, let's first understand the HPO axis. We know that hypothalamus is the main thing that secretes the gonadotropin releasing hormones, which Dr. Chaitanya sir is going to speak about, which stimulates the pituitary to secrete FSH and LH. FSH largely stimulates the folliculogenesis and, of course, responsible for the estradiol production. And the LH is important for ovulation, maturation of the follicle, and, of course, rise in the estradiol. The LH and the FSH together at the ovarian level would secrete their own hormones, and which is guided by a negative feedback by the estradiol and progesterone, thereby giving a negative feedback on the hypothalamus and the pituitary. So basically, let's understand the gonadotropic control of the follicular growth and function, which is important. So life cycle of a pre-ovulatory follicle can be broken down into 3 successive phases. First is initiation, which occurs from the birth to senescence. FSH-dependent progression requires a good tonic stimulation by the FSH, and LH-responsive maturation is when the FSH-induced genes fall under the LH control, leading to the final follicular maturation. Now, basically, when we know the menstrual cycle, especially for the postgraduates, we know that we start from the recruitment phase or the follicular phase, in which the antral follicle is recruited, it grows, and then once it becomes dominant, the first peak is your estradiol peak. After 24 hours, it is the LH surge. After 48 hours, it is the progesterone starts surging, which goes at a peak at around day 21, 22, and then followed by the second estradiol peak in the luteal phase. Now, this shows the relationship. This shows the relationship between gonadotropins, follicular development, gonadal secretion, and the endometrial changes. So FSH-LH not only affects the follicle, but it is also important for the receptors at the endometrial level also to synchronize with the development of the follicle, which starts right from transition from the secondary follicle to the antral follicle, being dominant, ovulation, and forming the corpus luteum. And we know that there are estrogen and progesterone receptors, alpha and beta, which are present in the endometrium, which have to synchronize with the level of the estradiol. Now, let's see what is FSH and LH. So FSH and LH are nothing but steroid hormones with an alpha and beta subunit, as shown in the figure. We have to know what is the difference in the half-life to be able to treat our patients impeccably. So the half-life of FSH is only 3 to 4 hours, and that of LH is around 20 to 30 hours, with a carboxyl terminal segment which is absent in both, and it is important to know the structure to be able to use it wisely in COH patients. So basically, in short, the function of FSH is recruitment of the follicle, selection of the dominant follicle, and to establish and grow this dominance. LH is important also for dominance, maturation of this follicle, and inciting the ovulation. So FSH, which is produced by the anterior pituitary under the influence of GnRH, is nothing but a glycoprotein dimer with alpha and beta subunits. The beta subunit is similar to the LH, TSH, and HCG, and the FSH is important for the growth and development, pubertal maturation, and reproductive physiology. There are several actions of FSH which are important for growing the follicle every month, stimulating the estradiol secretion, synthesizing the FSH receptors, synthesis of LH receptors in theca and granulosa cell, and also helps in synthesis of estrogens in the granulosa cell through aromatization of the androgens. In short, it incites an paracrine and autocrine activity in the follicles, thereby stimulating the activin and inhibin from the granulosa cells. So basically, there are 2 concepts which have to be understood whenever we are talking about FSH. First is the threshold, second is the FSH window. Now, what is the threshold? Threshold is the level of FSH which has to be crossed for recruitment of the dominant follicle from the antral pool. So whenever the FSH reaches this threshold, beyond this, the folliculogenesis starts. What is the window? Window is the period during which the folliculogenesis and growth of the follicle occurs. These 2 concepts are extremely vitally important whenever we are talking about recruitment and dominance of follicles during IUI cycles and IVF controlled ovarian stimulation protocols. So this again shows us gonadotropin independent phase, which is between primordial follicle, primary follicle, and secondary follicle, and the gonadotropin dependent and also the dependent phase for the external gonadotropins, which is the preantral and the early antral follicle. We know that FSH-LH varies between this recruitment to dominance and ovulation, and LH is the main thing, which is LH dependence starts basically post-ovulation to form a good functional corpus luteum. So how does the FSH actually cause the follicular dominance? So there's a selective rise in the FSH beyond the critical threshold, which we said in the previous graph, during the luteofollicular transition, which acts as a potent stimulus for the follicular recruitment, and several early antral follicles begin to enlarge in this phase because of the mitogenic action of FSH on the granulosa cells. Now, this LH, normally follicular growth requires both FSH and LH. And during controlled ovarian stimulation, exogenous FSH supplementation will lead to a good recruitment of the follicular pool, and thereby providing the endogenous provided the endogenous activity is optimum. So in patients in which this endogenous activity is not good, that is the time when the LH supplementation would be required. Now, there are various specific actions of LH if we see. It induces androgen secretion from the theca cells, granulosa cells, and converts by aromatase activity. It is important for proliferation, differentiation, and release of the follicular theca cells. Under the LH effect, the primary oocyte actually enters into the final meiotic division and is converted into a secondary oocyte, which thereby promotes the corpus luteum maintenance and stimulates the progesterone production as well. It is also important in males, as we know, for production of the male hormone or the testosterone. Now, what do we know about the 2-cell-2 gonadotropin theory? This is very important when we are talking about controlled ovarian stimulation protocols, especially where fertility is concerned. So we have one follicle which has theca and granulosa cells, and our hormones are attaching to receptors of two different cells in the same follicle and carrying out the function. So if we see this image, the LH binds to the LH receptor, incites the cyclic AMP activity, stimulates and transition from cholesterol to androstenedione, which crosses the basement membrane. Androstenedione later stimulates estrone production to a 17-beta active form of estradiol in the granulosa cell. So basically, we need to understand that it's a synchronous thing which is going on when two hormones, FSH and LH, gonadotropins, are acting on two different cells but in the same cell follicle, so that simultaneously these activities are going on. Now, so that means in the early follicular phase, FSH receptors are present on the granulosa cell, LH are present only on the theca cell. As the progression occurs, when the follicle exceeds around 12 millimeters, LH receptors start appearing in the same granulosa cell, and these together bring about the local elevation in IGF-1, IGF-2, inhibin B levels, which actually programs the follicular maturation, resumes the meiosis, and is responsible for ovulation. Now, let's study these two important concepts when we are talking about LH. LH ceiling and LH window and LH threshold. So what is the LH ceiling? So one has to understand that FSH, LH both are important for folliculogenesis and maturation. But beyond a certain level of the LH, that is beyond the LH ceiling, it becomes hazardous for the maturation of the follicle. So optimum level of LH is very important. If it exceeds that LH ceiling level, beyond that LH level, it is going to cause a deterioration in the folliculogenesis, and this has to be understood especially in IVF cycles. Again, LH threshold is the minimum level of LH which is required for causing ovulation and for action of maturation of the oocyte. So LH ceiling basically is around more than 5 international units. If you go, then it becomes hazardous for the folliculogenesis, but optimally at least 1.2 to 5 is required for a good follicle to develop and mature. So there is, of course, rationale of LH supplementation during controlled ovarian stimulation protocols in patients like hypogonadotropic hypogonadism, deeply suppressed LH, advanced reproductive age patients. Patients especially are Poseidon criteria with a low ovarian reserve, hypo-response patient to exogenous FSH, and of course, LH has a role to prevent the OHSS as well. So basically, to sum up the gonadotropins with activity, let us see gonadotropins having FSH activity, which are externally available, are our urinary HMG with an FSH LH 1:1, uropholiotropins, highly purified urinary FSH, and our recombinant technologies like folitropin alpha and folitropin beta. LH activity is obtained mostly from the urinary menopausal women, which has a HCG-like LH activity, from recombinant LH, which is leverous, urinary and recombinant HCGs, which have LH-like activity, and combination of FSH and LH in 2:1 ratio, which is easily available. So this is where whenever we require LH activity, all these things can be supplemented. Timing and dose of LH is very important. LH has to be supplemented basically exogenously. At least more than 75 international unit is required in hypo patients, and in poor ovarian reserve patients or patients with Poseidon criteria 2 and 4, we generally recommend the LH supplementation maybe in the form of recombinant FSH LH or HMG right from first day of stimulation to get a better cohort as compared to singularly using recombinant FSH. Now, apart from fertility, are there any other roles of gonadotropins? And the answer is yes. So basically, first role, puberty and sexual development. FSH and LH surge at the time of puberty, which are responsible for growth of the reproductive organs, development of secondary sexual characters in males as well as females, emotional changes, cognitive changes, especially during adolescence. Clinical applications are also there when we consider gonadotropins, especially for diagnosis of pubertal disorders like the precocious puberty or the delayed puberty, and to differentiate between the both. Now, there are certain other roles in menstrual irregularity patients, like evaluation of primary and secondary amenorrhea. In PCO patients, elevated LH disrupts the ovulation, thereby increasing the LH-FSH ratio. Sometimes it is reversed, very high AMH. So it doesn't basically help in diagnosis, but it is important for clinical suspicion. Menopausal transition and menopause. So rising FSH levels more than 25 on 2 separate occasions are seen in menopausal transition phase, when the woman experiences frequent menses, which are followed by intermittent skipped periods. And this period is followed by a menopause, which is complete cessation for more than a year's time, and then characterized by FSH peak levels of more than 40 international units. Certain other gonadotropin usage or roles have been deciphered in the recent emerging research and newer avenues, which I would like to discuss. That is, it is important for monitoring the gonadotoxic treatments, like whenever the patient is undergoing chemotherapy or radiotherapy, it damages their gonads, and hence the FSH levels are used to monitor the recovery or damage to the HPG axis. It has been found to have a role in Alzheimer's disease, contributing to cognitive decline, inflammation and anti-aging, especially neuroinflammation, by increasing the interleukin beta levels, interleukin 6 levels, which is important and associated with age-related cognitive decline and dysfunctions. There is also an interesting neurodegeneration link in postmenopausal women with factors which have been linked to the amyloid beta and the tau proteins, and FSH might bind to the receptors in the brain, thereby promoting oxidative stress and neuronal dysfunction. So brain-specific FSH receptors have also been deciphered. There have been studies which have detected the FSH receptors in the hippocampus and the cortex regions, which are important for memory as well as emotions. So both these things are affected by our elevated FSH levels, especially during the postmenopausal period. So we have studied the role of FSH, LH in fertility practice, in especially puberty, reproductive age, menopause, and these are some interesting treatment modalities in which there has been a role of FSH, LH, which also has been deciphered. So thank you so much for a patient listening. And once again, I would like to thank the team for inviting me today. Thank you.
Thank you, Dr. Manjari. Your deliberation has been very precise, to the point, and giving out all the basic endocrinology of FSH, LH, and gonadotropin. And the basic endocrine, which was, say, 20, 25 years back, is no more now. It is all replaced by NUDAM, and new therapies have come out of it, as you have already enumerated. The FSH levels, especially in postmenopausal ladies, causing neurodegeneration, Alzheimer's, and then emotional disturbances. So we need to look after all these basic things very deeply, and so that we can apply it in our clinical practice. So my suggestion to the youngsters would be that first you go to the basics, learn it, and then listen to the people who are coming and talking to you about the products, how to use and not, where not to use. They're always saying, use this, use that, but you don't know why you are using it so nice at so many instances. So the basics have to be cleared at this very level so that you are very clear to when to use and when not to use. There are so many emerging indications for these gonadotrophins and gonadotrophin releasing hormones, as you've already enumerated. So very nice deliberation, Manjari. Thank you.
Thank you, madam.
Dr. Tripti, madam, can you give your expert comments, please?
Yeah, first of all, let me thank the team, particularly Dr. Para, for giving me this opportunity. And Dr. Manjari, you have very precisely described each and every point. And this is particularly the platform where the many of the youngsters, they are also joining, and they must be knowing right from the basics. And you have very clearly told everything that the FSH and LH, the role of them in the folliculogenesis, not only there, but also in the advanced stage for the further management. So at the end, you have also described the newer area where the use of the FSH and LH is there. And this will definitely prompt or definitely stimulate or make the other youngsters to research, to go into the research work in that area to find out many more literatures and to work out on it, so that in the coming years we may be seeing not only in the field of the infertility but in other diseases related to the old age problems, the role of the FSH and LH will be seen. So thank you so much for a very nice and very precise deliberation on the FSH and LH.
Thank you, madam.
Thank you once again, Dr. Manjari. Vaishali madam, can we proceed with our next talk with Dr. Ganpule sir?
Yes, please.
Can I have the CV of Dr. Chaitanya Ganpule, please? I invite upon Dr. Chaitanya Ganpule for his talk on GnRH and his analogs. Sir has been mentor, a guide. Sir is director of Pearls Women Clinic and Yash IVF in Pune. He is director at Satara Yash IVF. He is recipient of Times Health Icon 2020. He is invited and published many national and international journals as well. Sir has also written a chapter in Jeffcott's textbook of gynecology, FOGSI Focus, and others. Sir, I welcome you on this platform.
Thank you, Dr. Madhu, for that kind introduction. And before I share my screen, I would like to thank FOGSI President, Dr. Sunita Tandulwadkar, ICOG Chairperson, Dr. Parag Biniwale, Dr. Sheila Mane, Chairperson-elect, and Dr. Suvarna Khadilkar, Secretary General FOGSI, and Dr. Sarita Bhaderao, Secretary ICOG, for giving us an opportunity to be associated with ICOG in starting this particular web series on topics related to endocrinology. And we thought of this web series because we all know that most of us, if you remember your residency days, we almost kept all the topics of endocrinology for options. We never studied endocrinology to the extent that we should have studied back then. And then when you come into the practice, you get to know that everything in OBGYN is only about endocrinology and nothing else. So, to get that enthusiasm into the new postgraduate students, we thought of having this as a webinar series. And for this, Dr. Vaishali Kordenayak joined hands with me, and most of the work, most of the topics and everything has been suggested by her. And along with that, we have our coordinators, Dr. Manasi, Dr. Madhu, and Dr. Mansi, and Dr. Vinuta, who are helping us in this web series. I would also like to thank our chairpersons for today, Dr. Reena and Dr. Tripti, for accepting our invitation graciously and giving your inputs on these two very important topics on GnRH and FSH and LH. Because I joined a little late, we had to take Dr. Manjari's talk first. So whatever I am going to speak upon is the precursor of what is being discussed by Dr. Manjari. So let me start sharing my screen. I hope it's visible, Madhu.
Yes.
Yes,
Okay.
sir. Clear, sir.
So I'm going to discuss about GnRH and its analogs. What is the physiology and what is the applied physiology? So because if we have to understand the applied physiology of anything, we need to understand the physiology first. Unless we get the physiology right, it would be difficult for us to diagnose the applied physiology or the clinical applications of it. That's the reason why we have combined these two topics. I would be starting with the GnRH. What is the physiology of GnRH? What is GnRH analogs? What are the different types and what are the mechanisms of their actions? Then what is the clinical application of these different analogs? What are the advantages and limitations? And whether there are any recent advances and research in this particular field going on, I would be discussing that with you all. So as majority of us know that GnRH is a peptide hormone containing 10 amino acids. So in short, it is a decapeptide. And it was only the discovery of this sequence of 10 amino acids that we were able, to get the physiology of this particular hormone into place. It is synthesized by the preoptic neurons of the hypothalamus, and it forms an important part of the hypothalamo-pituitary ovarian axis. So whatever Dr. Manjari discussed about FSH and LH, its action on the ovary, the Graafian follicle, the granulosa cells, the theca cells, everything starts with the secretion of GnRH from the hypothalamus, and therefore it is also called as a master regulator of the hypothalamo-pituitary gonadal axis. I would like to correct this instead of HPO axis because it is also secreted in men and is also equally important for the reproductive function in men as well. It is also known as LHRH. However, recently or nowadays, GnRH is the name which is used quite widely. Now, there are different types of GnRH which are identified in the vertebrates. And in humans, it is referred to as GnRH1 or simply GnRH, while there are others which are referred to as GnRH2, GnRH3, GnRH4, so on and so forth, based on the different vertebrates in which it is found. GnRH was first discovered in 1970s by these two young gentlemen here, Roger Gilliman and Andrew Shelley, and they received a Nobel Prize for their contribution in the discovery of the peptide decapeptide structure of GnRH. What is the physiology of GnRH? GnRH cell bodies are located in the preoptic area and in the arcuate or the infundibular nucleus of the hypothalamus. So hypothalamus is the part of the brain which secretes GnRH, and it is secreted by the GnRH cell bodies which are located into the preoptic area of this hypothalamus. They form a neuronal eminence projecting into the median eminence, and then this median eminence secretes this hormone directly into the portal circulation. Now, we all know that portal circulation is a short network between the hypothalamus and the anterior pituitary, and therefore there is a direct supply or direct delivery of these hypothalamic hormones to the anterior pituitary without wastage of much of a hormone, and therefore very small amounts of hypothalamic hormones can also get a very big action at the end of the ladder. We all know that GnRH is secreted into distinct modes. One is called as a pulsatile mode and the other one is called as a surge mode. Now, what do I mean by pulsatile mode and surge mode? In pulsatile modes, there is secretion of GnRH for some time, then there is a gap of some time in between, and then there is again secretion of GnRH. So this is called as pulsatile mode. So whenever there is a pulse, there is presence of GnRH hormone in the circulation, and whenever there is off the pulse mode, there is undetectable levels of GnRH which are found, they are not found in the circulation. As against, the surge mode is seen around the pre-ovulatory when the GnRH levels are found to be persistent. If we see the LH pulses are found to be dependent upon the underlying GnRH pulses, and therefore the LH pulse and GnRH pulse go hand in hand. This GnRH pulse frequency varies throughout the menstrual cycle. So how does it vary throughout the menstrual cycle? So in the follicular phase, you can see here, the frequency is around 1 hour. So it is secreted every hourly, culminating ultimately into the late follicular phase or pre-ovulatory phase into a surge mode. And this surge mode is required because we need to have an LH surge for the ovulation to take place. And therefore, this pulsatility in the GnRH should get converted into a surge because, as I said, the LH pulse frequency mimics the GnRH pulse frequency. So whenever there is an GnRH pulse, there is an LH pulse going on simultaneously. And therefore, if I need to have an LH surge, there has to be a GnRH surge or GnRH persistency as well. And therefore, initially, whenever there is a pulsatility in the GnRH secretion, it gets culminated into a surge mode around the period of ovulation. Well, later on in the luteal phase, if you see here that this pulse frequency decreases dramatically. So every hour in the luteal phase it goes on to every 2 to 3 hours, and that is why there is suppression of FSH and LH pulse frequencies as well. Second important thing what we need to understand here is that the GnRH pulse or the stimulatory effects of GnRH on LH and FSH are not identical. LH goes hand in hand with GnRH, while FSH is not dependent completely on GnRH pulses, or the changes in the GnRH pulses will not identically affect the changes in the FSH. So the decrease in the FSH is slower than the decrease in the LH after the pulse is shut off. That's an important difference between the two that we need to understand. Well, why do I need this pulsatility in the GnRH secretion? What is the relevance? So let's understand the relevance. Appropriate modulation of this GnRH pulse is important for the pubertal function and the reproductive function. So what happens? Initially, in the early infancy, there is an increased GnRH pulse frequency leading to increase in LH and FSH, and this is termed as mini puberty. Now, after this mini puberty gets over in the early infancy period, then there is a quiescence for quite a long time, wherein the GnRH pulse frequency decreases dramatically, so that the FSH and LH levels are almost undetectable during the late infancy, early childhood, till the time she reaches an age of puberty. Now, at the time of puberty, again, this GnRH pulsatility increases, and ultimately it leads into increase in the LH and FSH levels, leading to menstruation and leading to puberty. Now, if there is an abnormal reactivation of this GnRH pulse frequency, so instead of getting it reactivated around the time of puberty, if it gets reactivated a little early, then it can lead to what we term as precocious puberty, specifically the central precocious puberty. So that's how, or that's why this GnRH pulsatility is very important for us, so that all the effects can be understood and we can make use of this GnRH pulsatility for different applications in clinical practice. Now, how is this GnRH secretion regulated? Well, GnRH secretion does not have a negative feedback in the form what we expect. So what we expect, if it's the high estrogen levels or the high progesterone levels, which is going to give me a negative feedback to the pituitary and to the hypothalamus, what I should expect that there are receptors which are present on the hypothalamus, and that receptors get occupied by the estrogen, and therefore there is decrease in the secretion of GnRH. That doesn't happen because the GnRH neurons do not have an estrogen or progesterone receptors. So this signaling of GnRH secretion regulation happens to something called as kisspeptin signaling. This is not the time to go into the depth of this kisspeptin signaling, but it is a very very interesting, topic to read about this kisspeptin signaling in the control of this GnRH secretion. What are the different reasons, or what are the different things that can regulate the GnRH secretion? As I said, the estrogen, progesterone, and testosterone levels will have a feedback onto it. Presence of inflammation, both acute and chronic illnesses, will have an impact on the GnRH secretion. Stress levels will also have an impact on the GnRH secretion. Certain drugs like opioids, drugs stimulating prolactin secretion will also have an impact on the GnRH secretion, because we all know hyperprolactinemia leads to decrease in the pulse frequency of GnRH secretion, leading to amenorrhea as well. Metabolic factors such as energy or leptin deficiency and hyperglycemia can also have an impact on GnRH secretion. And then again, estrogen and testosterone, as I said, can have a direct action on the pituitary as well. So estrogen and progesterone are the hormones which have dual feedback mechanism. First, it can affect the pituitary. Second, it can also affect the hypothalamus and the secretion of GnRH. However, as I said, it is through the kisspeptin signaling that this regulation of GnRH takes place. Now, before proceeding ahead, let's discuss something about the HPO axis and the axis in the men as well. Hypothalamus is the organ which secretes GnRH, which has an impact on the anterior pituitary, which in turn secretes FSH and LH. Both of them have an effect on the Graafian follicle, which is present in the ovary, leading to the secretion of E2 and progesterone, which acts on the uterus and also gives a negative feedback to both pituitary as well as the hypothalamus, thus decreasing the GnRH secretion whenever the E2 and progesterone levels are high. Now, what happens in men? Well, again, hypothalamus secretes GnRH, which acts on the anterior pituitary, which in turn secretes FSH and LH. Now, FSH act on the Sertoli cells, while the LH act on the Leydig cells. FSH is responsible for the development of the sperms or initiation of the spermatogenesis, while LH acts on the Leydig cells which are present in the institution and lead to the secretion of testosterone. So if I have to reduce the levels of testosterone in men, because of whatever reasons, GnRH analogs could be of help. I'm going to discuss about it in a short time. Before again going forward, I would also like to take a couple of minutes of yours to discuss the two-cell, two-hormone theory, in which we say that there are two cells present in the Graafian follicle, the theca cell and the granulosa cell, and there are two hormones which are secreted by the pituitary, especially specifically LH and FSH, out of which LH acts on the theca cells predominantly, while FSH acts on the granulosa cells predominantly. Now, LH acts on the theca cells, wherein the substrate, that is cholesterol, gets converted into androgens. Then these androgens are carried from the theca cells into the granulosa cells, wherein the FSH acts on it and get it converted into estrogens. So if I have to have estrogen levels rising from the granulosa cells, I need to have androgen which is produced by the theca cells under the influence of LH. Now, this is important for us to understand, because when it comes to a case of hypogonadotrophic hypogonadism, it is both FSH and LH which are lacking, and therefore if I supplement them with only FSH, I will see a follicle which is growing, but I will not see a good endometrium, because the estrogen levels will always be less. Since I am not giving LH, there won't be any substrate which gets converted into androgens, and because of the lack of androgens, there will be less levels of estrogens in this particular woman. So it's important for us to understand this, that in a woman with hypogonadotrophic hypogonadism, amenorrhea secondary to this should be given either FSH and LH, or we can also be giving GnRH agonists or analogs. Okay. What is the applied physiology of this GnRH pulsatility? Now, what will happen if this pulsatility gets changed? Well, first thing what I was talking about is in hypothalamic amenorrhea, the pulsatility of this GnRH, and that's the reason why in turn LH is slowed down to the luteal phase frequency, leading to anovulatory amenorrhea and hyperestrogenism. In hyperprolactinemic amenorrhea, again, this LH and GnRH pulse frequency is reduced. and it requires dopaminergic agonists to reduce the prolactin levels and restore this pulse frequency of GnRH. Once this GnRH pulsatility is restored, there is increased pulsatility in LH and FSH, and everything or menstruation gets back to normal. On the other hand, in PCOS women, we see that this LH pulse frequency is much higher than normal and which is present throughout the menstrual cycle, and this leads to the characteristic of PCO appearing ovaries, changes in the hormonal levels, and irregularity in the menses. So we have both extremes wherein we have low pulsatility and we have excess pulsatility. Both of them are not good. We need to have a balance of between the two to have a proper action of this GnRH on the pituitary. Now, once we have understood the GnRH physiology, let's go on to look at what are the analogs. What are these analogs? What are the different types and what are the mechanism of actions for each one of them? Now, analog are the substances that are modified in structure from the original structure for greater potency and duration. So the work for development of analogs started once we established the structure of GnRH as a decapeptide. After that, there were quite a few attempts, to get something which is more potent and which acts for a longer duration of time. And that's where we got these GnRH analogs. Now, these GnRH analogs were initially developed to achieve more potent fertility effects. But what they found was that there is a paradoxical anti-fertility effect on its continuous use. And that's the reason why we went on to have a different application of these GnRH analogs when we found that on continuous use, it gives me a different result. When I am using it for a short time, it is giving me a different result. So they are basically used for the modification of hypothalamo-pituitary gonadal axis. There are two different types of analogs which are there. First one is the agonist. The second one is an antagonist. The mechanism of action for both of them is different. Let's understand the mechanism of action for agonist first, and then we'll go on to antagonist. Well, agonists are the ones which have a very strong and prolonged affinity to GnRH receptors. So these are the substances which are similar to GnRH in structure, have a very strong and prolonged affinity to GnRH receptors which are present on the anterior pituitary. So what they do, whenever I administer a GnRH agonist, they go and get attached or bind to the GnRH receptors into the anterior pituitary. Now, they not only bind, but also activate the GnRH receptors after binding. Once it is activated, obviously there is going to be a secretion of FSH and LH at the other end. However, because it occupies the receptor for a longer period of time, initial signaling will give a rise in FSH and LH, but later on, just occupying it. So you have to understand this. Whenever there is an antigen antibody binding, the initial binding only will give the activate the post receptor mechanism. So it will not keep on activated the post receptor mechanism. It gets bound, it activates the post receptor mechanism, and that's it. So later on, it has to get detached from it. The receptor has to be free again. Another GnRH molecule should come and get attached or get bound to the receptor, which will again reactivate the post receptor mechanism. So if something is binding to the receptor for a prolonged period of time, it is going to lead to desensitization. That means eventually it will lead to decrease in the FSH and LH levels and downregulation of the receptors as well. The GnRH agonists are available in injectable and nasal spray. Bioavailability after oral administration of most of these GnRH agonists is less than 1%, and therefore oral preparations are not suitable, and therefore they are not available as well. What are the Examples of GnRH agonists, well, leuprolin, buserelin, triptorelin, naferelin. There are so many different types of GnRH agonists which have been discovered based on their affinity and strong positive response. They are different in nature. But at the same time, as I said, because there is a desensitization, there is decrease in FSH and LH over a longer usage, it has got its side effects as well. It creates a scenario wherein the woman will experience hot flushes, loss of interest in sex, that is decreased libido, inability to obtain or sustain an erection, that is impotence, increased bone pain due to disease, flare during first couple of treatments, headache, vaginal dryness, swelling of breasts, depression, sleepiness, skin rash, and over a longer period of time, uses over a longer period of time will lead to bone loss, osteoporosis as well. What are GnRH antagonists then? These are the substances that bind to GnRH receptors. However, they will just bind. They will not activate the receptors. So there is no activation of post-receptor mechanism. So there is no secretion of FSH and LH after it gets bound to the GnRH receptors. And therefore, the flare-up response is not seen in antagonists. And there is an immediate decrease in the FSH and LH levels after usage of these antagonists. Fortunately, these are available now in an injectable forms as well as oral forms. The oral form of antagonist has recently been introduced in January, February in our country. Till then, even the antagonists were also available in the injectable form. Now, this is how it acts. As I said, GnRH agonists are acting on the receptors at the pituitary level. Initially, they give a flare-up response and followed by desensitization, while GnRH antagonist will bind competitively with the receptors at the anterior pituitary level and will not activate the receptors. Therefore, there won't be any flare-up response and there will be immediate decrease in the FSH and LH secretion by the anterior pituitary. Well, what are the clinical applications of these agonists and antagonists? Most important use of these analogs have been in the fertility management. We all know that controlled ovarian stimulation is the hallmark of fertility ART. Before going ahead with that, I would like to spend a couple of slides on what are the types of ovulation inductions and what is our aim or objective of this ovulation induction. So there are three types of ovulation inductions. One is to correct the ovulatory disorder, that is dysovulation. Here, majority of the times we are using oral ovulogens. Then superovulation or IUI, in which we aim at developing more than one follicle. So 2 or 3 follicles are developed. And then lastly, the controlled ovarian hyperstimulation, where we want to have maximum number of follicles developed, which is the basis of IVF and ICSI. But as I start stimulating this with any of the drugs, especially the gonadotropins, my LH levels, my estrogen and my progesterone levels are going to go up. Now, as my estrogen and progesterone levels start going up, the LH surge is initiated by the estrogen levels, rising estrogen levels, and the presence of little bit of progesterone. Now, if this high estrogen levels give a premature LH surge, it will lead to premature luteinization of the ovarian Graafian follicle, and that will not give me pregnancy. And that is why whenever I am having a controlled ovarian stimulation, I should have something which will prevent this LH surge as well. So the aim of controlled ovarian stimulation is to induce follicular growth. It initiates, augments, or modulates the growth of follicles. It overcomes the process of natural selection, allows maximum number of follicles to grow. More number of follicles are available for retrieval and fertilization. But as I said, it can lead to premature LH surge, and therefore to prevent this premature LH surge, I can use these GnRH analogs. Now, in controlled ovarian hyperstimulation, it is used to downregulate the pituitary and prevent the secretion of endogenous gonadotropin. So what I want here is, I want the entire control to be in my hand. I don't want her pituitary to secrete any FSH and LH, because whatever FSH and LH I am giving from outside will have an superseded action of this FSH and LH which is secreted by the pituitary. So I don't want them to secrete any FSH and LH. I should be giving those from outside. So everything is under my control. So to do that, I can use these GnRH analogs. Both agonists as well as antagonists can be used for this downregulation of the pituitary. Now, I can use analogs to downregulate the pituitary again in FET cycles if I'm going for a hormonal cycle FET. That means I'm not doing a natural cycle FET. I'm going for a hormonal cycle FET, in which I would be giving again estrogen from outside. So if I am giving estrogen from outside, I don't want the pituitary to act on my ovary and secrete estrogen endogenously, because then again I would not get when the LH surge would occur, when the progesterone will come, and premature appearance of progesterone will decrease my chances of fertility, because implantation rates will reduce. Now, also it is used in women who have got PCOS and who are at high risk of development of OHSS. So normally what we do for trigger, we give HCG, but HCG has got a very long half-life, and therefore the chances of OHSS are more with the use of HCG. So instead of that, I use GnRH agonist for triggering, because it has got a short half-life. It will not give me OHSS. So it is used to trigger in women which are at high risk of OHSS. Can I use it in male infertility? Yes, these can be used to treat the male infertility due to hypothalamic hypogonadotrophic hypogonadism. At least 3 to 6 months of pulsatile infusions are required before significant numbers of sperm are observed. That is the way how I can use GnRH agonists in men to procure or produce the sperms. Another area where I can use these GnRH analogs is endometriosis. We all know that endometriosis is an estrogen-dependent pathology, and therefore the use of agonists or antagonists, which induces the hypoestrogenic state and inactivates the endometriosis implants, can be used as a part of the treatment. However, the effects are temporary, and stoppage of medications will reactivate these lesions. They are used for getting relief from endometriosis-associated pain and regression of the lesions. Prolonged hypoestrogenic state can lead to side effects like hot flushes, irritability, and bone loss. And therefore, if I am going to use agonists as a treatment modality for endometriosis, I cannot use it for more than 6 months without add-back therapy. If I have to use them for some reason for more than 6 months, I need to have an add-back therapy. Now, what do I mean by add-back therapy? That means I want to maintain the estrogen levels at a certain level, and therefore I add on estrogen and progesterone in addition to giving this GnRH agonist to maintain that estrogen level. Now, here there is a very nice concept put by Barberry, and it is called as an estrogen threshold hypothesis. Now, what do I mean by estrogen threshold hypothesis? See, we have got different tissues in the body which are responsive to estrogen, but the levels at which they become responsive are different. Therefore, bone is the most sensitive organ. So very small amounts of estrogen are sufficient enough for us to have the calcium deposition into the bone. Similarly, endometriosis growth is seen with very high levels of estrogen. So can I have something which will maintain my estrogen levels into that sweet spot, or into that sweet range of about, say, 30 to 60 picograms per ml. Therefore, it is not. So if it is less than 20 picograms per ml, you will have bone loss. So if I have estradiol levels which are more than 20 picograms, but less than 60 picograms, it will prevent the growth of endometriotic implants. At the same time, it will not cause the bone loss. So this sweet window is achieved by this oral antagonist, which is introduced lately into the market, called as elagolix. However, it has to be given in the dose of 150 milligram, because if you give it in a higher dose, which is 200 milligram twice a day, it leads to the estradiol concentration in the range of 12 picograms, which again leads to bone loss. So if I am using 200 milligrams, it cannot be used for more than 6 months. If I am going to use 150 milligrams, the DGC has given an approval for 24 months, that is 2 years. Can I use these analogs in uterine fibroids? Again, these are benign tumors that are arising from the myometrium. Again, they are estrogen-dependent tumors. So anything which is estrogen-dependent can be treated by either agonist or antagonist. However, again, we have to remember one thing, that all these are temporary methods. Till the time she is on agonist or antagonist, she will have low levels of estrogen and the volume of the fibroids will be reduced. As soon as I stop the medication, it will bounce back, and it will take some time for it to come back to the same size or increase, but it is going to come back, it is going to increase. So it's a temporary method. So usually it is used in women who are waiting for the surgery, or if they are willing for pregnancy and I want to shrink the fibroid temporarily, transfer the embryos, get a pregnancy, and post delivery, maybe I go for a surgical intervention. Now, it can also be used in combination with anti-androgen therapy with GnRH agonists like leuprolide, goserelin, histrelin, and triptorelin in the treatment of prostatic cancers, because they help in reducing the serum testosterone levels and its after effects. So it is very well used in prostatic cancer patients as well. It is also used as a continuous treatment for central precocious puberty. Here I am, taking advantage of the long duration of its effect and desensitization and downregulation, which leads to decrease in FSH and LH levels, decrease in estrogen, progesterone, thus preventing the bone growth, preventing the improving the bone growth, and because shortening or short stature is what is found in women who have got precocious puberty. Then transgender hormone therapy is another way by which these agonists are used. It acts as puberty blockers and it supports in transition related care. So friends, to conclude, GnRH is a master hormone of reproduction. There are two types of analogs which are available, agonists and antagonists. There are widespread indications for the use of these analogs as we discussed. However, there is still scope for the development of an oral agonist. Oral antagonist we do have with us, but we can still, think of developing an oral agonist, and those with fewer side effects. So this is what I wanted to discuss about GnRH and its analogs, the physiology and the applied physiology. I hope I have given justice to the topic as expected. Thank you so much for your patient hearing.
Thank you, Dr. Chaitanya. I would like to congratulate you for the way you have explained the physiology and its applications in clinical practice. I think all the people sitting over here, the youngsters, the postgraduates must have understood how to understand the physiology and how to apply it in clinical scenario. That was very, very well explained. And especially I liked your blackboard with chalk slides, very nice. It took us to the era of, say, 20, 30 years back when
Right.
we used to write on the blackboard and teach
Right.
the students. That was very nice and very well explained, all the scenario. Very, very nice. I think people must have understood it very nicely. Thank you so much.
This
Thank you
is
so much.
this is his favorite format. His slides are always the chalkboard and
That was
the,
very nice.
the slate feeling.
Yeah.
Always
Right.
very nice.
Dr. Chaitanya actually explains also in a similar manner, as if we are just listening to a learned teacher and just grasping every word what he's saying. So excellent presentation, Dr. Chaitanya, and particularly GnRH analog, as you have rightly said, it is the master hormone. That is very true. And we have to understand when to use which particular analog, whether antagonist or agonist. That very well explained by you, as well as the recent upcoming the molecule which is coming for the management of the endometriosis. I am definitely I say that this is one of the field where most of the treatment is being tried and the people are not getting enough relief. And I know that this particular newer molecule that is going to help a lot in the endometriosis. And as you have rightly said, that it has not only the role in the reproduction, because it is the hormone which is throughout the reproductive life. So it has got tremendous uses. The only thing is to explore and to use the right dose and the right type of the molecule in the management of different diseases or different situations. So thank you so much, Dr. Chaitanya, for an excellent presentation. I really liked it. Mesmerizing kind of your lecture. Thank you so much, sir.
Thank you, Dr. Tripti. Thank you so
And
much.
one more thing I would like to say, that you've very well explained that these effects are temporary. We should counsel the patient, because
Right.
patient will always come and say, "Mera to wapas aa gaya, the things have come back." So
Sahi hai.
the counseling part is very, very important before prescribing these GnRH analogs and antagonists. That is very important.
Thank you, ma'am.
Thank you, Reena ma'am and Tripti ma'am, for your expert advices onto it. Of course, Chaitanya sir talk is always something takeaway messages into the clinical
Right.
practice. Thank you, sir.
Thank you.
I hand over the discussion to have any question and answer session from the young people around in this meeting. Do we have any questions?
I don't see anything in the chat box.
Yes, correct, ma'am. So we proceed with the quiz then.
Yes, I think so.
Okay, I'll call upon Dr. Mansi Sharma, a close friend, to please proceed for the quiz. Can I have a CV of Dr. Mansi on the display?
I think we will proceed with the quiz.
Thanks,
Very
Mansi.
comprehensive and very detailed lecture. I think all of us learned a lot today from the lecture. So let's move forward with the quiz. And I would like to, at the outset, I would like to thank Dr. Srinita Tandurkar, Dr. Parag Biniwale, Dr. Chaitanya Gunpule, and Dr. Vaishali Kudinayak ma'am to give me this opportunity. What we are going to do is, there is going to be a QR code on your screen. Khushi, can I have the QR code on the, yeah.
Yes, ma'am. Yes,
May I
I'll share.
request everyone to join the quiz through the QR code? We are going to wait for some time so that all of you can join. We have a 5-round quiz on this topic. Each round contains 5 questions. So there are total 25 questions on the topic which we have taken today. Khushi, do we also have a WhatsApp link for the quiz for people who are not able to join through the QR code? Is it
Yes, ma'am.
possible for us?
Yes,
Yes.
let me just give me 1 minute. I'm stop my screen sharing and I'll be sharing link in the chat box.
Yeah, so the link will also be there in the chat box. So I request everyone to join through the link or through the QR code, which is visible on the screen. Yeah, the link has been shared in the chat box. And we will be, yeah, and the QR code is visible on the screen. Please let me know if anybody is having any problems in joining the quiz. Do we have the participants now? Kushi, I'm not able to see anything on the screen. Don't start the question. Acha, yeah.
Yes, ma'am.
We
Yes.
will be waiting for 1 minute more so that more people
Okay.
can join us. You can join in between the quiz also, but we will wait for 1 minute more so that everyone can start with the first round.
Yes. 12 player has
It
joined.
has joined. We will just wait for 1 more minute. And I request everyone, yeah. So the first round which we have is a Pechan Con round, which is a visual round. So in this round, we have the questions which are in the visual form, and you have to identify the related to the questions. I think we will start with the quiz. Okay, so let's move on to the first question, first round.
So everyone, you need to click on the answer and you need to submit on.
Yeah, so you have to identify this famous personality. I think Ganpule sir's first slide was this, so it's very easy. The options are Andrew V. Skelly, Richard J. Stanton, Russell Marker, or Edgar Allan. He was awarded the Nobel Prize in 1977 for his discovery. Yes. Oh, so only 3 right answer. The correct answer is Andrew V. Skelly. He was credited with the discovery of GnRH hormone with Roger Guillemin in 1971, and he was awarded the Nobel Prize in 1977. May we have the next question, please? So the next question for this round is, you have to identify this syndrome. There is a picture on that where, yes, whether it is McCune-Albright syndrome, whether it is Kalman syndrome, whether it is testicular feminization syndrome, or none of the above. If you can see very clearly, there is a cross mark there. Something is not going somewhere. I'm giving you a hint. There is a migration which is not happening. So what is that syndrome where migration of something is not happening? Time's up. Yes, we have 10 correct answer. That's Kalman syndrome, where due to defect in certain genes, the migration of GnRH does not take place, leading to hypogonadotropic hypogonadism. Can we have the next question, please? Okay, you have to identify the phenomena seen in the figure. It is associated with the mechanism of action of which? This also question has been taken up by Dr. Chaitanya Ganpule. Whether it is the action of GnRH antagonist, whether it is the action of GnRH agonist, none of the above, or both A and B. You can see there is no intrinsic activity. There is competitive receptor blocking. There is no LH-FSH action. You can see the picture properly. I've given you all the hint. Yes, 5 of you are correct. It is GnRH antagonist. Okay, can we have the next question, please? Okay, you have to identify this structure, whether it is FSH, LH, GnRH agonist, or GnRH antagonist. It is slightly tough, but the picture has been taken from Speroff, so very clear-cut picture. There is a change in the 6th position of the amino acid. So I'm also giving you a hint. There has been change at the 6th position of the amino acid. Okay, 5 of you are correct. That is GnRH agonist. So when the position at the 6th position of the amino acid substitution takes place, it is a GnRH agonist. Can we have the next question, please? Yeah, so in that picture, there is an endometriosis GnRH analog has been used. So which of the GnRH analog mechanism helps reduce endometriosis related pain? Whether it is sustained LH, high LH release, whether it is suppression of the pituitary gonadotropin release, whether it is increased FSH secretion, or whether it is pulsatile GnRH stimulation. You have to identify the phenomena which helps with the reduce endometriosis related pain. Yes, 7 of you are correct. It is suppression of the pituitary gonadotropin release. So can we have the leaderboard score after this round? At the first position, we have Yukti, followed by Sranjana, Tripura, and Poonam Mehta. We move on to the second round. The first question for this round, please. GnRH is produced in which part of the hypothalamus, whether it is arcuate nucleus, supraoptic nucleus, paraventricular nucleus, or preoptic area? Very straightforward question. We have 15 seconds remaining. Okay, 4 of you are correct. The correct answer is arcuate nucleus in the median part of the nucleus. Can we have the next question? What is function of GnRH pulses in regulating the FSH and LH release, also covered in the presentation? Constant high GnRH stimulate FSH and LH. Low frequency GnRH stimulate LH. High frequency stimulate FSH. High frequency stimulate LH. Low frequency stimulate FSH. Or GnRH has no effect on the FSH and LH release. Again related to the phase of the menstrual cycle. Okay, so the correct answer is C, again taken from Speroff. The high frequency GnRH pulses stimulate the LH release during the follicular phase of the menstrual cycle. It shifts during the luteal phase of the menstrual cycle to the low frequency pulses, which favors the FSH release. Can we have the next question, please? What is the role of inhibin in the reproductive hormone feedback loop? Whether it stimulates the GnRH release, whether it inhibits FSH secretion, whether it enhances LH secretion, whether it promotes follicle development. Can we have the 9 of you are correct? It inhibits FSH secretion. Can we have the next question, please? So LH acts via tyrosine kinase receptor, nuclear receptor, G protein coupled receptor, or ion channel. We are talking about receptor here. Very, very straightforward question, simple question. Yes, the correct answer is G protein coupled receptor. Can we have the 10th question? This is the last question for this round. The physiological GnRH pulse frequency for LH predominance is, we are talking about the LH predominance, 1 pulse every 24 hours, whether it is continuous, whether it is 1 pulse every 60 to 90 minutes, or none. It is not, LH is not pulse dependent. Yes, the correct answer is C, 1 pulse every 60 to 90 minutes. With this, can I have the leaderboard, please? Okay, it remains, there is slight change in the leaderboard with Yukti leading, followed by Anand Deleshmi K, Tripura and Poonam Kumari. So we move on to the third round. The first question for the third round is, can we have the first question for this round, please? What is the effect of low level of estrogen on FSH and LH secretion? It increases both FSH and LH. It decreases both FSH and LH. It increases FSH but decreases LH. It decreases FSH but increases LH. We are talking about secretion, not synthesis and storage. I've already given the hint. Okay. So this question is purposely kept for confusion. See, low level of estrogen increases the storage and synthesis, but it decreases the secretion of FSH. So the correct answer is B. It decreases both FSH and LH. All are true about FSH except it stimulates aromatase activity in granulosa cell, recruits antral follicles, directly stimulate theca cells for androgen production. Its secretion is regulated by inhibin B. Yes, 9 of you are correct. It is the activity of LH, not FSH. Can we have the next question, please? The FLAIR protocol in IVF uses GnRH agonist because initial rise in FSH-LH boosts follicular recruitment, suppresses endogenous gonadotropin instantly, it directly blocks estradiol synthesis or prevent OHSs. You have to give the right answer. One of this is more correct. You have to give the right answer. Yes, the correct answer is initial rise in FSH-LS boost follicular recruitment. Can we have the next question, please? After using GnRH agonist for 6 months for fibroid, which hormone level is expected to be most suppressed? Whether it is prolactin, whether it is estradiol, whether it is testosterone, or whether it is progesterone. We just discussed this. Yes, the correct answer is estradiol. Can we have the next question for this round, please? Which of the following is a paradoxical effect of continuous GnRH agonist use, whether it is increased pituitary FSH secretion, whether it is suppressed LH secretion, whether it is increased ovulation rate, whether it is hyperandrogenism? You have to say which of these is the correct answer. Yes, 7 of you are correct. Suppress LH secretion due to pituitary downregulation. Can we have the next leaderboard score, please? It remains same. And Anand Lakshmi has the longest correct answer streak. Otherwise, the scoreboard remains same. We move on to the 4th round. Which of the following is not a GnRH agonist, whether it is leuprolide, goserlin, ganirelix, or buserlin? Which of this is not a GnRH agonist? Yes, 10 of you are correct. Ganirelix is the correct answer. Can we have the next question? A woman with anovulatory infertility is given HMG. Its advantage over recombinant FSH alone is it contains LH activity, it is cheaper but less effective, there is no risk of OHS, or it blocks endogenous LH. You have to tell the advantage of HMG over recombinant FSH alone. The advantage. Yes, 7 of you are correct. It contains the LH activity. That is the advantage of HMG over recombinant FSH. Can we have the next question, please? Which drug suppresses LH surge while maintaining FSH stimulation during ART cycle of these? Letrozole, GnRH antagonist, clomiphene citrate, or bromocriptine? Which of these is the much correct answer? Yes, 9 of you are correct. The correct answer is GnRH antagonist. Can we have the next question, please? An infertile woman with hypogonadotropic hypogonadism is given pure FSH therapy. Which outcome is least likely if LH is not supplemented? Whether it is estradiol rise, whether it is follicular growth, whether it is dominant follicle selection, or whether it is ovulation. We have discussed this in both our lectures today. Which outcome is least likely if LH is not supplemented in a hypogonadotropic hypogonadism? 4 of you are correct, ovulation, because hypogonadotropic hypogonadism does not have an internal LH activity. Unless you supplement an LH, the ovulation is not going to take place because an LH search is not going to be there. Can we have the next question, please? Continuous GnRH analog therapy is used for all except prostate cancer, uterine fibroids, precocious puberty, or ovulation induction. Ganpule sir has given all the indications today. So again, covered in the lecture. It is used for all except, for which we do not use this. You have to give the except. Yes, 8 of you are correct. Continuous therapy is not used for ovulation induction. So leaderboard after this round is, the scoreboard remains the same. So you have the last round to make some changes. So we have 5 more questions remaining. Can we have the last round, please? Which risk is common to both GnRH agonist and antagonist used in reproductive medicine? Ovarian hyperstimulation, thrombocytopenia, hyperprolactinemia, or adrenal suppression? Very straightforward question. What is the risk which is common to both GnRH agonist and antagonist? Yes, 9 of you are correct. Ovarian hyperstimulation is seen with both. Can we have the next question, please? What statement is true about OHS's risk? It is unrelated to FSH dose. It is higher with GnRH antagonist protocols. Triggering ovulation with GnRH agonist instead with HCG can reduce risk. It does not occur with PCOS. This also we have covered in the last lecture. You have to say the correct statement about OHS. What of this is correct? Yes. Triggering the ovulation with GnRH agonist instead of HCG can reduce the risk. Correct. Can I have the next question, please? Which GnRH analog is approved as an oral GnRH antagonist for endometriosis management? Leuprolide acetate, triptorelin, elagolix, or nafarelin? Again, a very easy answer. All of you are correct. It is elagolix. Can we have the next question, please? A patient on GnRH agonist for large fibroid develops significant menopausal symptoms. Which strategy is best to minimize the side effects while maintaining fibroid shrinkage? Whether you should discontinue GnRH immediately, whether it is add-back therapy with low-dose estrogen progesterone, whether it is increasing the GnRH agonist dose, or whether it is add high progesterone only. Yes, it is the add-back therapy with low-dose estrogen plus progesterone. Now we have the last question for this round. During a long GnRH agonist IVF protocol, what is the typical timing of gonadotropin or FSH administration? Immediately after the first GnRH dose, whether it is 1 to 2 weeks after the GnRH dose starting, after the downregulation, whether it is only after the LH surge, or whether it is only after the ovulation is confirmed. Yes, we have all the correct answer. Correct answer is B. So the leaderboard after this is there is slight change with Yukti on the first position, followed by Poonam, Anand Lakshmi, and Dr. Mangesh. So may I have a round of applause for all the winners. Congratulations. And thank you for participating in the quiz. Can I request Dr. Vishali ma'am to give the vote of thanks, please?
Okay. Very nice quiz, Mansi. It was very interesting, very nice questions, and loved the quiz. So we come to the end of this session, and I would like to thank Biniwal, who's working this session throughout the month. All our chairpersons were very kind and they praised our speakers a lot. Both the talks were very crisp and they really simplified the topic. So I would like to thank both Dr. Jiri and Dr. Chaitanya Ganpule. And at the same time, the quiz master, Dr. Mansi, thank you so much. It was excellent. Thank you and see you next month on third Wednesday with the next session. Please join us.
Thank you, ma'am. Thank you, everyone, for being so attentive and participative in this session. We look forward for our series to continue. We meet you next month. Thank you, everyone. Good evening.
Thank you, all of you, the ICOG, the Endocrine Committee, Dr. Parag, everybody. Thank you so much. I enjoyed it thoroughly.
Thank you so much, ma'am.